Welcome to the Arrhythmia Electrophysiology Round Table, hosted by Touch Briefings and supported by the European Heart Rhythm Association and doctors.net.uk. So if we could get to discussion session 1, which will be about service, and would anyone like to start with referral pathway?
Well, thank you very much. I have the honor and privilege to open the discussion today. Well, referral pathway is quite heterogeneous as we are talking about Europe. And Europe is, for us, is European Society of Cardiology, 54 countries. So this obviously indicates that we can only cover some of the geographies. And we very well know that there is a substantial problem in a good and proper referral between general cardiologists and electrophysiologists. There is also obviously some obstacles in the referral between the general practitioners and cardiologists as well. I think if we have to look into the European reality, which is again is significantly heterogeneous, and probably we have many people here coming from different countries, and probably each of them can present the reality in their own country. I can start, for example, in Switzerland and Italy, two countries which I am best aware of. I think that there are probably few problems related to the referral, which is, first of all, is about the dissemination of guidelines. So the European Society of Cardiology is presenting and producing and updating continuously guidelines. And frequently guidelines, unfortunately, have not been able to be translated in what everyday practice most of our colleagues, they do see and they do have. I think one of the problem is certainly that guidelines are very broadly written, so they have very general topics. So once you come into apply to one specific patient, you find obstacles related to the fact that you have significant comorbidities, you have obstacles related to the willingness of patients to enter in one specific treatment, and you also have the difficulty of applying one specific therapy because of reimbursement. So I think those are really the three probably key part of the problem. I think that in each nation and each geography has some peculiarities or some specific issue related to one of these three key points. For an example, I think in Italy, most of the problem is, and depends very much which kind of treatment we are talking about. We can talk about referral for implantation of cardiovascular implantable devices like pacemakers, implantable cardioverter defibrillator or CRT. This is a particular situation. There is the other one mostly related to the treatment, I would say a curative treatment of some catheter ablation procedures, which we can really offer a curative treatment to many of those patients. And there are some others which I will now define more probably partially palliative, partially curative treatment in catheter ablation, and this I'm referring to atrial fibrillation, for example. And then there are some others which are more related to general topic, which it looks like management of syncope and assessment of syncope patients, and so far and so on. I think that is really the spectrum is so huge and so broad that probably we need to define one of this one. Probably, if I may ask Joseph to define, let me say, for catheter ablation, for example, what are in this country, because Czech Republic is a very advanced country within the Central and Eastern Europe, but I think still there, despite significant progress that they have done, I think we still see a lot of issue in getting patients properly referred. And also, I would say probably when they go back to the primary care physicians, the problem question is what I have to do, how I can do, and how I can stay in the loop of information.
Well, we launched many years ago some regular meetings with referral centers. Each of our centers usually has a structure and they create a series of events, educational events. So you go to district hospital and you have like a symposium or seminar and discuss with them indications, and they know you personally, so they can refer patients. So this is a very good way how to improve relationship between those referral physicians and center. And we also try to really minimize some obstacles to bring patients to center. So if they have, for instance, any acute problem, they can call. We have on-call service in our department. They can call and you can discuss some arrhythmic storm or malfunctions of devices, things like that are emergency situations. So this is an issue that helps to have a relationship between referral centers and centers performing EP.
So awareness is one, but I think another major problem is access. And we have, in the line that also Joseph mentioned, made the barrier to refer patients lower, because we know that even if a physician, a general practitioner or a cardiologist sees a patient, wants to refer him and wants to send him to the clinic, then there is a waiting list of weeks, sometimes months. So what we have set up is a system where not only we have an on-call system, but they can also submit queries, so to say, by email or by fax, and we answer them always within the first day. And I see that many cases, not only emergencies, but many arrhythmia cases are referred and they send ECGs and Holters. And in fact, in most of the cases, we can make a very clear management proposal to them, which may involve referring the patient for an ablation 2 or 3 weeks later, but which often may involve a strategy of drug treatment that they can immediately start. So I think lowering the barriers by having some sort of service disseminating management plans to referring physicians definitely helps.
I think there's also a problem with the referrer's belief in the therapy. So certainly in the UK, we found that referral rates for devices are pretty high now because a lot of EP doctors are involved in implanting devices, and the data is very powerful supporting their use. But for more complex problems like atrial fibrillation ablation, there is still a lot of skepticism about the value of the therapy. And it's remarkable that even in meetings populated by EP doctors, if they are not involved in AF ablation, they will be very skeptical about the therapy and be reluctant to refer on. And of course the challenge we have is that the very people that do very well are the ones that they never see again. They only see the ones that are more complex, that don't get a success from ablation. So they have a very skewed view of the world of AF ablation, for example. So I think we have a big challenge to prove that the therapy works, prove that it's cost effective, because in the next decade, as Angela already implied, reimbursement is going to be the big challenge to us. We're already seeing reimbursement becoming an issue for some of these more complex therapies because we have not been able to prove cost effectiveness yet.
Well, I think, again, if I can go back to my Switzerland or Italy, I think that part of the major problem or link between general practitioner and cardiologists, indeed the skepticism in general about the effectiveness of some therapies and some treatments, essentially. And this is also probably is also a matter of expectation. I think for some specific therapies, and I'm thinking about AF, for example, I think people, they really expect that you can really definitively cure the patients in 99% of the cases with one single procedure and get the people off of drug. And I think this is probably also a matter of communication from the electrophysiologists that, for example, AF ablation is a very powerful and very good treatment, but obviously we also need to fine-tuning to the patient's characteristics. So I think that is also a matter of probably discuss with the general practitioner of the referral to say, well, in this specific case, I may expect probably not the curative treatment or a definitive, say, complete treatment of the patients, but say it may be possible that a recurrence, it is highly probable because of the substrate, because of the age of patient, because of the underlying disease. So, and I think that is also probably gives more confidence in the therapy as well. I think it's a bidirectional communication. So how we present the therapy as electrophysiologists, they do openly and free speaks about the effectiveness and also long-term effectiveness of the therapy, because this is more and more commonly we know, and we have now data on 3 and 5 years follow-up, but we really don't know what happened in 7 or 8 years, so significantly longer follow-up, and for different diseases. So this is also part of the inability of properly communicating our results.
But I think it's fascinating that we, as an EP community, have a sort of characteristic that's slightly apologetic about our results, but yet when you compare ablation to angioplasty,
oh, yes.
it's superb. I don't want to use superlatives here, but it is the figures speak for themselves, that the success rates for AF ablation are in the long term better than they might be for some angioplasty cases, and yet there's no doubt that angioplasty is an accepted and appropriate therapy.
If I might jump in Germany we see the clear-cut leading role of the ESC guidelines in paving the referral pathways. I mean, over the last couple of years, the ESC and the ERA has established a set of treatment guidelines that really provide good solutions for many medical situations. We have to make sure that the different levels within the medical system gets access to these guidelines, because at the end of the day, a lot, if not all, is in there for the key questions to be asked: what to do with the individual patient. And guideline adherent patient referral, guideline adherent patient therapy is the key issue for the next years, especially on the background of shrinking resources in the medical sector. We have to come up with solutions which are best for the individual patients, and I think that the guidelines provide the key information necessary to do so.
Gerhard, can I ask how that plays in Germany? Because in the UK, people will then, physicians will tend to say, oh, that's European guidelines, that doesn't really apply to UK practice. Is that the case in other countries in Europe? So they'll ignore European guidelines because they're European and not national?
Yeah, in Germany it's not the case. It's more and more accepted that the European Society of Cardiology has a leading role in constructing the guidelines. It's a consensus that has been made with input from all the members of the European Society of Cardiology. So what we do in Germany, we translate the guidelines in a one-to-one fashion into German language, and there are few commentaries that try to explain how the guidelines can be best implemented in the German healthcare system. I think it makes sense. So the key issues are transferred one-to-one, and some commentaries explain how to get along with the guidelines. And I'm really happy to say that the guidelines are more and more recognized and more accepted.
I think, yes, the situation what you have in UK is because you also have a NICE, which is essentially a governmental agencies, which is very much interested in also providing cost-effectiveness therapies. So I think the unique situation you have in UK is the fact that you are trying to make science and money coming together. Yeah. Where in most of the other countries in Europe, we are still focusing very much on just on the science. But we know, for example, that there are some attempts to have health technology assessment agencies, national agencies, who are really reviewing the science and trying to make this one more looking to cost effectiveness, or translate this one for more cost effectiveness point of view. And I think this is where now we have not seen yet this process coming. I mean, we still look very much at NICE as a reference agency, but in general I think that this dichotomy between scientific data and more cost-oriented data has not happened so strong as you have in UK. But Pierre, you want to comment?
Yeah, I mean, exactly the point. I mean, in UK, we're very much cost-efficacy focused, and actually that means there are a lot of patients actually fall through the cracks because when it's straightforward, the NICE guidance can be applied, but a lot of patients are in a grey zone where one can debate the evidence for appropriateness. So we've now adopted the policy of having, we call them MDTs, combined meetings between, if it's, say, for example, left atrial appendage occlusion, between neurologists and cardiologists to try and identify the patients most likely to benefit from the technology, because the NICE guidance isn't actually there. And similarly for cardiomyopathy patients, the evidence base is not quite as structured as it would be for the large ICD randomized controlled trial. So again, you need the authorities actually do accept the MDT combined opinion for the appropriateness of a treatment. And even more fundamental, actually, is we're talking very high level about arrhythmia management, but there have been a number of studies in the UK, and I'm sure in Europe, where people have taken very simple ECGs to do surveys and given them to general physicians for simple things like complete heart block, and that's being missed on the ECG. So we have a major obligation, really, to educate our general physician colleagues to recognise very, very simple electrocardiographic diagnoses where there's a very robust evidence base for therapy. And we sometimes probably get very focused on our particular high-level technical interests, and actually very simple things like diagnosing complete heart block, atrial flutter, or bifascicular block on a patient with pre-syncope, how that should trigger a referral from an electrophysiologist. And I think that's something we really have an obligation to do, not only to our general cardiology colleagues who should know better, but to the general physicians who definitely often have forgotten a lot of cardiology, I think.
And it's an interesting point you make there, Pierre, because about the triggering a referral to an electrophysiologist, many of the referrals in that situation will come, certainly in my experience, from a general practitioner to Dear Cardiology, and the general practitioner is not necessarily aware that there is a subspecialty called cardiac electrophysiology, where our mandate is specifically the management of patients with heart rhythm disturbances. And so that's about education again, communicating to general practitioners that this is a specific branch of cardiology. There's expertise across all cardiologists in the management of heart rhythm problems, but really the best management of heart rhythm problems will be by doctors who are trained in the management of those problems. So I think that's very important.
Yeah, I want to come back also in this respect to the guidelines and their implementation. I think implementation is often thought of as disseminating them towards the physicians. But I think implementation is mainly on how do you apply them in real patient care, because there's the real problem. And often patient care is very complex. And I think maybe even if a general practitioner recognizes a problem, then there's still the challenge on how do I address this. So we talked already about access to arrhythmia services and having a low threshold for sending a query and getting advice. But I think that more and more hospitals now are starting to experiment with nurse-coordinated arrhythmia clinics, where a nurse can receive the query, can assemble the whole details about the patient, present it to an expert, an electrophysiologist, and then feedback a management plan to the general practitioner with very practical advice on when the patient should be seen, what the patient should receive on drugs, whether any specific technical intervention is necessary. And we have set up such a nurse-led arrhythmia clinic for atrial fibrillation patients, and I must say that this seems to be a very effective way of really reaching out to general practitioners and patients.
Well, I think that the point that you're bringing up is about, I think it's good to have also this kind of nurses-based filtering or triage, if you like. But I don't think it's really a practice all across Europe. I think in general, there's still, I think it's sort of, again, reluctance to consider non-pharmacological therapies for many of the patients. And I'm thinking of, again, atrial fibrillation, but also to, if you think about CRT, which is now a very established, very powerful therapy. I think still general practitioners are first trying to exhaust the entire spectrum of antiarrhythmic drug before to consider again to think about an ablation, or to think, well, let's try with the next beta blocker, let's try to the next ACE inhibitors, next try to angiotensin receptor blocker before we do consider a device-based therapy. So, and this is also a matter of both probably discussion of the indication, again bringing also more and more the news and the awareness around possible treatments to general practitioners. And I don't know how to make that possible to say, well, once you start to think about an antiarrhythmic drug for AF, but why you don't consider also another therapy? And I think this is probably Richard was referring to the fact that we're usually more apologetic and try to be more defensive there rather than to be proactive in the way which do present the therapy. But I don't know how to best make this kind of translation of so good therapies that we have. And so again, when you have pharmacology versus non-pharmacology, please consider also pharmacology as a first-line therapy rather than really keep the patients 3-4 years when the disease is so advanced, then the outcome of any other treatment, which is non-pharmacology, is probably minimal or modest, or probably less likely to happen. Again, we know now CRT, if you take CRT in class 2, has extraordinarily good results, and when you go into a class 3 and 4, so very advanced stage, the outcome is probably less favorable. So that is the kind of things where the threshold for referral should also be, or which should change the threshold.
One of the challenges that we have is that general practitioners or family doctors have so many things that they have to know about. It's very difficult for them to remain current. And one of the consistent feedbacks we get through patients and patient charities is that their frustration at the delay in getting to see someone with a special interest in their problem. And that person can be a nurse. We get very, very good feedback from patients about nurses. We have nurses sitting in primary care practices, serving several practices, offering an arrhythmia service. And in our experience, about 88% of those patients end up getting treated and discharged by the nurse successfully. They don't get referred on to tertiary care or secondary care. So it's a model that can work, and we can convince healthcare purchasers that this is cost effective, and it means that those patients that really benefit from CRT or from ablation are the ones that are going to get sent early. And I think that may be a model to overcome that problem.
I think this is crucial, because the vast majority of patients presenting to their general practitioner will be presenting with palpitations as the sort of heralding event. But like Richard says, many of these patients will not have an arrhythmia as the substrate for their palpitations, or certainly will not have an arrhythmia that requires anything more than reassurance that they have a structurally normal heart and don't require any pharmacotherapy for it. So we definitely don't have the resource in this country to see every single patient with palpitations in a secondary or tertiary setting, and we do need to have closer apposition of the expertise for arrhythmia care to the patient, but that does not necessarily need to be in a hospital setting, and I think this is really a model for the future in the UK.
In Germany, we have a more and more direct referral from the general practitioner to the EP specialists. I mean, over the last 10, 15 years, most big hospitals in Germany installed specialized electrophysiology, and that has been recognized step by step by the medical community. Years back, the referral pathway was from the general practitioner to the cardiologist, and only a part of the patients that should have been seen by an EP specialist then made the last step from the cardiologist to the EP specialist. That has changed over time. What also did change is the awareness of the cardiologists and the general practitioners that we can do a lot for the patients, especially in the field of electrical treatment of heart failure and in the field of atrial fibrillation. If we go through our data, we recognize that we fortunately see the patients earlier for interventional treatment as compared to a couple of years ago. So we are on a good path in order to improve the quality of the treatment. If we continue what we do now, that's awareness, education, and paving pathways.
It's as you said, it's a complex process. There's many facets, and we rely also on direct access, and we rely on patient organizations. We rely on some education through websites, and we rely on education of physicians in meetings, like general cardiology meeting, where we have a lot of symposia on treatment, indications, results. So this all makes referrals more easy and more appropriate for any physician and any patient.